Hey, how's it going? So this video is going to be on mood disorders, and more specifically, it's going to be on the affective spectrum. So this video is going to go into detail on the different diagnoses in the mood disorder spectrum, and hopefully will make it easier with regards to how to think about the different diagnoses, and also I'll give some tips in terms of what those diagnoses means for treatment implications. And I'm taking a lot of this from Dr. Gainey's book, Mood Disorder, A Practical Guide. He just puts all this stuff together really well, and I found his synthesis to be really helpful, and I thought it'd be worth it to make a video on it. So to start, here's a nice picture of the affective spectrum, essentially the mood disorder spectrum. And seeing it like this can make it a little confusing, so we're going to go into all the different diagnoses here, so that by the end of the video, you'll be able to look at this and have it make a little bit more sense. So why is this continuum perspective helpful? So the DSM uses categorical diagnoses, which is really helpful for learning the content and for doing research. But as a clinician, you'll see a lot of patients that don't fit neatly into these categories. So the spectrum or continuum approach allows us to understand that diagnostic categories are classic extremes on a spectrum and helps us to reconcile that these diagnostic categories are very useful, but that we have a lot of patients that have features for more than one category and patients that don't match perfectly to our diagnostic labels. So this model helps us recognize that patient symptoms can be a blend of different disorders, and we shouldn't try to shove them into a single diagnostic box. So I'm going to go through all the different diagnoses on these spectrums so you have a better idea and grasp of what's going on. But before we jump into that, let's discuss the importance of diagnosing mood disorders. So mood disorders are really central to every psychiatric evaluation, and we can understand this by understanding the diagnostic hierarchy. So the diagnostic hierarchy in psychiatry emphasizes evaluating and ruling out certain conditions before diagnosing conditions below it on the hierarchy. And the reason for this approach is that it ensures that clinicians identify the underlying cause of symptoms and make sure that they're accurately treating diagnoses rather than treating manifest symptoms. So it helps minimize misdiagnosis and improve patient care. So when we look at this hierarchy, the diagnoses lower on the hierarchy should not be made if a higher tier diagnosis is present and currently symptomatic. So to clarify here, I'm not saying a patient never has comorbid conditions across the hierarchy, but that you shouldn't diagnose the lower ones if a patient has active symptoms of ones higher up above. So for example, looking at the hierarchy, a mood disorder should be assessed prior to diagnosing a psychotic disorder or an anxiety disorder or personality disorder. So by ruling out higher priority conditions, you reduce the risk of misdiagnosing a secondary disorder that may be a manifestation of a more primary condition. And by identifying the primary disorder, it ensures that treatment targets the cause of the symptoms. And as we can see, the diagnostic hierarchy of psychiatric disorders, first is mood disorders, then psychotic disorders, then anxiety disorders, then personality disorders, and then other disorders like ADHD, eating disorders, conversion disorders, dissociative disorders, or sexual disorders. So some diagnostic implications here. You shouldn't diagnose something like schizophrenia if the psychotic symptoms are due to a mood disorder. In that case, you should be thinking more of a psychotic unipolar depression or a bipolar with psychotic features. And then a personality disorder shouldn't be diagnosed unless the mood disorders are absent and the patient is euthymic and they're not in an active mood disorder. And then looking at the bottom of the hierarchy, you shouldn't diagnose ADHD in the presence of an active mood disorder because the mood symptoms can mimic that condition. Now, again, I'm not saying someone can't have a mood disorder and ADHD, but just that you shouldn't diagnose ADHD during an active mood disorder. So assessment for mood disorders is essential not only for patients with mood symptoms, but in those presenting with pretty much any psychiatric symptoms. So with this diagnostic hierarchy in mind, let's review the different diagnoses in the mood disorders and an approach to making the diagnosis. So let's start with depression. And I'm starting with depression because if someone has hypomania or mania, that's a lot more specific for a bipolar illness. Whereas depression is a little bit more complicated. And that's because depression is a syndrome, not a diagnosis. So this can be a little bit confusing. What's a syndrome? What's a symptom? What's a sign? So a symptom is just a subjective experience reported by the patient. Examples include pain, fatigue, nausea, dizziness. So symptoms are subjective and determined from patients' descriptions. A sign is an objective indication of a medical condition that can be observed by someone else. Examples are a rash, elevated blood pressure, or a fever. Now, a syndrome is a collection of signs and symptoms that consistently occur together and that categorize a particular medical condition. And a syndrome is different from a disease because a disease has a specific known cause, whereas a syndrome may or may not have a clearly identifiable origin. So a symptom refers to a single indication of a condition, whereas a syndrome encompasses a group of signs and symptoms that together suggest a specific health issue. So depression itself is a syndrome. So a good analogy, if a patient came to the hospital with a fever and abdominal pain, you don't say that their diagnosis is fever and abdominal pain. When you see a fever / you see depression, you really need to look for the diagnosis. So the diagnosis means that you're identifying the illness that is producing the depressive symptoms. So when you see depression, there's a few steps you want to take. The first step is determine if it's a primary or secondary depression. So when I say secondary depression, I'm talking about substance abuse or a medical illness that is directly causing the symptoms of depression. So secondary depression is only diagnosed if a definitive cause is identified. So there needs to be absolute evidence of causation. And that's because probable and possible relationships better represent triggers and not clear etiology. And that's why I think having psychosocial on here can be a little bit confusing, because someone can have a trigger that is psychosocial and have a primary depression. So to be secondary, it needs to be absolute and clearly a certain etiology. So let's say you get past step 1 and you've ruled out a secondary depression. Step 2 is determining if the depression is unipolar or bipolar depression. So the basics here are just to assess if there's been a past manic or past hypomanic episode. And if there's been just a single manic or hypomanic episode, that establishes the diagnosis of bipolar. And when you're looking for symptoms of hypomania, mania, of course, you're using the dig fast symptoms. And here's just a tip. The most reliable and useful manic criteria is a decreased need for sleep. So when you're looking for mania or hypomania, it can be first helpful to identify a period where someone had a decreased need for sleep, and then from there, assess for other manic symptoms during that time frame. So the key takeaway here is that to diagnose unipolar depression, you first have to rule out secondary and bipolar depression. Now, it's worth noting that there are some features of a depressive episode that suggest bipolarity. Said another way, bipolar depression has certain features. So the depressive episodes in bipolar depression tend to be brief, less than 3 months. Episodes are recurrent, so you'll see someone with a lot of episodes of depression. There are certain subtypes of depression which are more common with bipolar, atypical and psychotic, especially if the person is under 25 years old. And someone experiencing bipolar depression, you're going to see a lot of treatment resistance to antidepressants. So patients that have failed 3 or more antidepressants, you should be wondering if it's maybe a bipolar process. Other features are antidepressant-induced mania or hypomania, a family history of bipolar disorder type 1, and possibly substance use or psychotic disorders, and a hyperthymic personality in between episodes. So a hyperthymic personality is characterized by consistently elevated, energetic, positive mood. These are people who temperamentally have high energy levels, reduced need for sleep. They're talkative, sociable, optimistic kind of people. All right, now let's move on and go into a little bit more detail on the subtypes of the different mood conditions. So here I'm going to differentiate dysthymia from major depressive disorder. And then I'm going to look at the different varieties of major depressive disorder. So for major depressive disorder, 50% of people have a single episode and don't have a recurrence. And 50% of people have a recurrent course. And then there are different specifiers of major depressive disorder, but I'll get into those in a little bit. As I mentioned here, the core distinction I'm making is dysthymia versus major depressive disorder. And in DSM-5, dysthymia is also called persistent depressive disorder. So the definition of dysthymia is mild depressive symptoms, typically at least 2, but not 4, of the DSM symptoms. And the symptoms occur for more than half the time for at least 2 years, and there's never a euthymic period lasting more than a month. And it's important to note that to call someone pure dysthymia, that means that they've never had a major depressive episode ever, which is something that's actually pretty uncommon. So more frequently, dysthymia will occur alongside with recurrent major depression. And when you see a picture of someone with major depressive episodes and dysthymia in between those episodes, we call that double depression. Now, one thing that's worth noting about dysthymia is that there's a really big overlap between dysthymia and generalized anxiety disorder. So on the slide, I'll show a picture of the criteria for GAD, but the gist really is just 6 months of a chronic anxious mood with excessive worry. So the key distinction between dysthymia and GAD technically is a chronic depressed mood in dysthymia versus a chronic anxious mood in GAD, but the truth is you'll see patients will often meet criteria for both. And that's because we see mild chronic depression and anxiety kind of go hand in hand. So patients often present with chronic mild depression and anxiety together. So historically, I'm talking about pre-DSM-3, these patients who had this dysthymia GAD picture were diagnosed with what was called neurotic depression, which I think is a term that might do a little bit of a better job capturing that mildly depressed, mildly anxious patient that is commonly seen in outpatient practice. And that's because neurotic depression just more accurately captures the experiences of these individuals rather than the more rigid feeling GAD or dysthymia. So in current practice, we often see these patients treated with antidepressants and sometimes anxiolytics. And this can be conceived of as symptom-oriented therapy because these patients typically aren't diagnosable with true recurrent primary unipolar depression, but can be seen as having a more mild depression and anxiety symptoms that just fall short of threshold of severity needed to define recurrent discrete episodes. So the antidepressants here actually have a pretty weak evidence base. A lot of these patients will spontaneously recover, and we know that psychotherapy is likely as effective and much safer than antidepressants here. Now, in the real world, convenience and insurance coverage makes it so that more and more antidepressants are prescribed here, but the truth is these patients would probably be better treated with therapy and without medication. And for a more historical perspective, dysthymia used to be conceived of as more of a personality type. So it was thought that these individuals had traits that included introversion, shyness, lack of enthusiasm, mild depression. And there's still debate on whether dysthymia is more of a personality trait or a distinct mood disorder. But regardless, there is functional impact with dysthymia. So people with dysthymia have less successful careers, greater difficulty with relationships. So it's not that they don't warrant treatment. It's just that the treatment isn't clearly medications in this disorder. And as I mentioned before, a patient can have dysthymia and major depressive disorder, in which case it's called double depression. So treatment and outcomes for double depression resemble that for chronic depression. So, hey, if you enjoyed this content, we'd really appreciate it if you supported the channel. Head on over to www.psycho.farm. So just .farm, not .com. There you can check out my comprehensive antidepressant course. There's also a link to Amazon for my book on treating depression, and also some information if you're interested in having me as a supervisor or a mentor or whatever. All right, let's get back to the video. So I'll use this time to talk about chronic depression. So chronic depression was added to the DSM-4, but it was taken out of the DSM-5. But I still think it's a useful category. So it's defined as meeting full major depressive criteria for a year or longer. So major depressive disorder is traditionally viewed as an episodic disorder, and we see episodes typically last 6 to 12 months in unipolar depression, and then 3 to 6 months in bipolar depression. So chronic depression represents a subgroup of unipolar depression patients that have episodes that last for years. And in regards to treatment implications, we're typically using the same standard antidepressants, and therapy is effective, especially when it's combined with antidepressants here. But medications are probably more important here, and you're really thinking about the long-term use of antidepressants, and you likely are going to keep an antidepressant on if it's working. All right, so taking a step back, I talked about dysthymia a little bit. Now to talk about major depressive disorder, as I mentioned, there's a few varieties. So there's patients who have a single episode and don't have it recur, and that actually occurs about half the time. Then there's patients who have a recurrent course, and that's the other half. And then there's also chronic, which I already talked about. So let's talk a little bit more about recurrent major depression. So half of individuals who get a major depressive episode will go on to have another episode. And it's worth making the distinction between single episode and recurrent because it has implications in regards to treatment approach and prognosis. So for the treatment of an initial episode of major depression, so that means you're not going to know if it's single episode or recurrent yet, then both medication and psychotherapy are effective for treating that single episode. Whereas for subsequent episodes, patients with recurrent depression usually require long-term medication to treatment. So to say that another way, when you're dealing with recurrent major depression, medications are more effective than psychotherapy alone. So medications are really a mainstay for recurrent depression, while they're really optional for a single episode of non-recurrent depression. So this is an important clinical insight. Clinicians often assess current symptoms, but overlook past episodes, which are really important for treatment planning. Because if you have an accurate history of depressive episodes, it really informs treatment intensity and treatment expectations. Because you're going to want to use different treatments if this is the second versus the 23rd episode of depression. And your expectations of when or if you're going to be pulling off these medications are very different for the two disorders. And a patient with recurrent episodes is probably going to require a more aggressive approach. Another thing is recurrent major depression is also just more likely to indicate bipolar disorder than a unipolar depression. So recurrent depression is often more severe than non-recurrent depression and is going to come with increased hospitalization and increased suicidal risk. If you're seeing these patients have frequent but brief depressive episodes from 2 weeks to 3 months, that may be signaling an underlying bipolarity. And what I mean by that is that some of these patients might be responding better to mood stabilizers rather than antidepressants. So key takeaways from these distinctions: recurrent depression generally requires medications, often combined with therapy. Recurrent depression is often more severe than single episode depression. And if you're seeing a patient with recurrent depression with short depressive episodes, maybe be on the lookout for a bipolar disorder. All right, now let's just quickly go into the different subtypes of the depressive syndromes. So in the DSM-5, these are considered specifiers. So the specifiers are with anxious distress, which, as I mentioned with the dysthymia, it's confusing to distinguish MDD with anxious distress versus GAD versus dysthymia. But the treatment implication is that you might have to add an anxiolytic medication. Then there's depression with mixed features. So that means the patient's having a major depressive episode with concurrent symptoms of mania or hypomania without meeting the full criteria. Treatment implications is that these patients may do better with a mood stabilizer or an atypical antipsychotic. Then there's with melancholic features, which may respond better to TCAs or electroshock therapy. Then there's atypical features, which may respond better to MAOIs, but SSRIs are commonly used. Now, atypical depression is more common in bipolar than unipolar depression. Then there's also depression with psychotic features, which often require a combination of an antidepressant and an antipsychotic. So young individuals under 25 who experience psychotic depression are more likely to manifest later as bipolar. Then there's depression with catatonia, which often requires benzos or ECT. Then there's depression with peripartum onset. There you'll prioritize therapy first, with medications considered based on the severity and safety to the mother. Then there's depression with seasonal pattern, essentially seasonal affective disorder, and the treatment implication there is you'll want to use light therapy. All right, so to recap so far, we talked about the affective spectrum, we talked about the diagnostic hierarchy, where we place mood disorders at the top, so we know it's important to treat mood disorders before considering other diagnoses. Then we talked about how if a patient presents with symptoms of depression, it's a syndrome, and it's important that we get to the underlying diagnosis and treat that diagnosis. So first we rule out secondary depression, and then we rule out bipolar depression. If we determine it's unipolar depression, we're looking at dysthymia versus MDD. If it's MDD, we want to distinguish if it's single episode or recurrent. And then I briefly flew through all the different specifiers and their implications for treatment. Now let's go into a little bit more detail on secondary depression. So as I mentioned, secondary depression occurs as a result of a medical condition, substance use, or medications. And common medical conditions associated with secondary depression are cardiac, endocrine conditions, and neurologic conditions. Substances we often see are alcohol, marijuana, opiates, and cocaine. Medications we commonly see are steroids, beta blockers, antiepileptics, benzos, antihistamines, antibiotics, and antihepatitis treatments. To go one by one into a little bit more detail, with cardiac illness, depression is both a risk factor and a consequence of cardiac disease. So that means depression makes it more likely that someone's going to have cardiac disease, and independently, someone with cardiac disease is more likely to get depression. With neurologic illness, here we're thinking of MS, dementia, and stroke. So depression can occur during or between epileptic episodes, ictal and interictal phenomena. With regard to dementia, depression's often early manifestation of Alzheimer's, but an elderly patient with depression can also look demented, and that's called pseudodementia. And we know depression is common following strokes, especially left frontal lobe lesions. With regard to endocrine diseases, we know that even mild cases of hypothyroidism can cause depression, and that depression is an early sign of being hypothyroid. And depression can also occur with Cushing's disease, and that makes sense because we know depressive symptoms are linked to changes in the HPA axis. With regards to substance use, we know that alcohol is the most common substance implicated in secondary depression. With regards to medications, ones that you should be on the lookout for, so steroids are the most common class of medications that can cause depression. They also can cause mania, though. Beta blockers are pretty common, neuroleptics, and that includes antiemetics like promethazine. Antiepileptics and benzos, particularly Klonopin, can cause depressive symptoms. Antiadrenergics and antihistamines, so even medications that are commonly used like clonidine and cimetidine, have been associated with depressive symptoms. So the key point here, if you're ever dealing with a cardiac, endocrine disease, or neurologic condition, be on the lookout for secondary depression. You should know the common medications that can lead to depression, steroids being the most frequent cause. And whenever you're dealing with depression in patients using these things or with these underlying conditions, you need to consider if the depressive symptoms are primary or secondary to the medical disorder, substance, or medication. All right, so we've covered the unipolar aspect of depression. Let's just talk a little bit about bipolar disorder. So to start with bipolar disorder, let's just go through the different subtypes. So the first subtype is bipolar disorder type 1. So bipolar 1 just means there's been at least one manic episode with or without depression. So you don't actually need depression to be bipolar 1. Then bipolar disorder type 2 means that there's been no manic episodes. So if there's ever been a manic episode, automatically type 1. So bipolar 2 is defined as at least one hypomanic episode and at least one major depressive episode. And I think it's worth here to discuss the difference between mania and hypomania. So the core difference really just has to do with the amount of functional impairment. So mania is defined as significant social or occupational dysfunction, whereas hypomania definitionally does not cause significant functional impairment. All right, the next subtype is cyclothymia, which is defined as subthreshold depressive symptoms with hypomanic symptoms lasting at least 2 years. The next is just pure mania, so the patient has euphoric or irritable mood episodes without any sort of depressive episodes. This technically would be a subtype of bipolar 1. Then there's mixed mania, which means the patient has depressed mood with manic features. And then there's rapid cycling, which is 4 mood episodes of any polarity in a year. So this is technically a course of illness and not a subtype. Now, another diagnosis that is controversial, but I think is really important, is bipolar disorder NOS. So NOS just means not otherwise specified. So this describes individuals who are on the bipolar spectrum who don't meet criteria for bipolar 1 or bipolar 2, but they also don't meet criteria for MDD or dysthymia. So generally, these are individuals with major depressive episodes who also have some features of bipolarity, whether it's family history or hypomanic episodes that don't last 4 days, or antidepressant-induced mania or hypomania. And I went over these earlier, but features of bipolarity are when the depressive episodes are brief, they're recurrent, commonly atypical or psychotic depression, especially in younger patients. They're treatment-resistant to antidepressants, and they've experienced antidepressant-induced mania or hypomania. Then there's a family history of bipolar disorder, and also possibly substance abuse and psychotic disorders, and a hyperthymic personality in between episodes. So bipolar NOS is a diagnosis that's really useful for patients on the bipolar spectrum. And these are patients that consist of features of bipolarity besides the classic kind that are found in the DSM criteria. And Dr. Gamey in the mood disorder book proposes a new diagnosis literally called bipolar spectrum, and notes that this occurs in patients with severe major depression that don't have spontaneous hypomania or mania, but they have a lot of other signs of bipolarity. So bipolar spectrum would address a gap in the DSM's not other specified category. And the reason this is potentially important is because it matters for treatment. So treatment strategies for bipolar spectrum disorder differ from those who have major depressive disorder or who have bipolar 1 or 2. And that's because antidepressants should be used very cautiously in bipolar spectrum disorder, and mood stabilizers or anticonvulsants should be prioritized. So patients with bipolar spectrum share features with both unipolar depression and classic bipolar, but they don't meet criteria for DSM bipolar 1 or 2, and they don't fit neatly into the unipolar depression category. So Dr. Gamey actually gives us a proposed definition with criteria of bipolar spectrum disorder that can be pretty useful. So the criteria is at least one major depressive episode, no spontaneous hypomanic or manic episodes, and then one of the following plus at least 2 of the next set of criteria. So a family history of bipolar in a first-degree relative, or antidepressant-induced mania or hypomania. And then the next set of criteria, if no items from the previous were met, you need at least 6 of the following. So a hyperthymic personality at baseline, recurrent major depressive episodes, more than 3, brief major depressive episodes, on average less than 3 months, atypical depressive symptoms, psychotic major depressive episodes, early age of onset of major depressive episodes, so younger than 25, postpartum depression, antidepressant quote-unquote wear-off, so that means they have an acute response but not prophylactic prevention, and lastly, lack of response to 3 or more antidepressant trials. So the important clinical implications of this diagnosis is that treatment of bipolar spectrum focuses on mood stabilizers or novel anticonvulsants rather than antidepressants. So if you diagnose bipolar spectrum, then you'd want to begin treatment with a low-dose lithium or valproate or a novel anticonvulsant. And you could use these medications as monotherapy in the absence of standard antidepressants. So the gist is that you're giving low dose of the mood stabilizers. Aside from treatment implications, I also find that bipolar spectrum disorder can be really helpful for patients to understand themselves. So the bipolar spectrum diagnosis can help an individual understand their subtle mood fluctuations and also help them appreciate the necessity of a mood stabilizer in their treatment plan. So I really like the bipolar spectrum disorder diagnosis and find that patients like it because they feel like it better captures what's going on with them in the absence of classic mania or hypomania. Now, just a few other topics I want to touch on in this video. As I mentioned, cyclothymia means major depressive symptoms that don't meet threshold for diagnosis of major depressive disorder, and mood elevation symptoms that don't reach threshold for a manic episode, but they can reach threshold for hypomania. So regarding treatment for cyclothymia, I would say it overlaps with bipolar spectrum disorder, where it's not unreasonable to use low-dose mood stabilizers like lithium or valproate, or use a medication like Lamictal. So in patients with bipolar 2 or cyclothymia, there's evidence that low valproate levels are sufficient for treatment, so like 30 to 60. And it's even possible that higher doses of valproate can worsen depressive symptoms. So the gist here is that you're really using lower doses. And the last thing I want to touch on is differentiating borderline personality disorder and bipolar 2 disorder. Now, to do this, you should be really focusing on the dig fast criteria to diagnose bipolar type 2. So in borderline personality disorder, there are rapid mood shifts. Now, compare that to rapid cycling bipolar disorder. So rapid cycling, a patient can have episodes that occur every few days or less, and it can be difficult to distinguish the rapid mood shifts of borderline personality disorder. The key distinction here is that hypomania is not just mood swings. So hypomania involves the presence of the dig fast symptoms in the same way as mania. So the dig fast symptoms are the same in number, it's just that their severity is less in hypomania. In contrast, patients with borderline won't meet dig fast criteria even for a few days. And also, patients with borderline personality disorder will have mood shifts along with other features of the disorder. So with borderline, you're not seeing the decreased need for sleep for 4 days or longer, or episodic increased talkativeness. And that's because the diagnostic criteria for bipolar are episodic, whereas borderline personality disorder, you're really seeing chronic symptoms. Now, with borderline, it can be helpful to de-emphasize the specific borderline personality disorder criteria and instead focus on the overall typical profile. Now, this is something you shouldn't be doing for mood disorders. So in borderline personality disorder, a typical patient will have a history of childhood abuse or neglect, which can be overt or covert. They'll have unstable relationships, all or nothing thinking, and quite often they'll elicit an aggressive countertransference feeling. So if a patient has mood swings without the dig fast criteria, then you should probably be thinking about borderline personality disorder. Now, it's worth noting, of course, there are people that have both conditions and would meet both dig fast criteria and have the typical profile of borderline personality disorder. And my last point, it's super important that you don't give a bipolar diagnosis just because you're uncomfortable telling someone you suspect they have borderline personality disorder. So it's incredibly important to communicate to the patient what you're thinking and why you're thinking that, because it just has such important implications with regards to treatment and prognosis. And it's not good for a patient whose symptoms are the result of a personality disorder to be thinking that their symptoms are the result of a mood disorder. All right, so in future videos, I'll probably go into more detail about bipolar, but in this video, I just wanted to make sure I got to the concept of bipolar spectrum and make sure I gave a good overview of diagnosing mood disorders and help you categorize patients into the different diagnoses. Thanks for watching.